Hi, my name is Will Munyon. I'm a third-year resident at Texas A&M Christus Spohn Emergency Medicine Residency.
The title of my study is Success Rates for Intubation During Manual and Mechanical Chest Compressions Under Simulated Conditions. I'd like to thank my contributing authors, Dr. Butler, Leeson, Zhu, Torres, and Richmond. I have no financial or non-financial disclosures. By way of introduction, sudden cardiac death accounts for approximately 15% of overall mortality. The American Heart Association emphasizes the importance of high-quality compressions, categorizing factors of appropriate rate, adequate depth, and minimal interruption. A prior mannequin study has identified significant deterioration with the quality of manual compressions over time. For these reasons, mechanical compression devices are becoming a prominent part of both in and out of hospital CPR. In regard to establishing an advanced airway during CPR, current ACLS guidelines leave the decision of if and when to progress to an advanced airway up to the individual practicing provider. A randomized clinical trial in patients with out-of-hospital cardiac arrest showed no significant difference in functional neurologic recovery between those receiving a supraglottic airway compared to those receiving endotracheal intubation. This data adds to the body of evidence that compression should not be halted in order to establish an advanced airway. In regards to intubation during CPR, a study using cadavers and pre-hospital providers using direct laryngoscopy showed 97% success rates without compressions compared to 77% success rates during compressions. However, our literature review showed no prior studies comparing intubation attempts between manual and mechanically driven compressions. The objective of this study was to evaluate ease of intubation, operator confidence, and success rates for intubation between mechanical CPR and manual chest compressions. The study's design was a prospective crossover trial, the setting an academic emergency department simulation center, and the participants 32 emergency department physicians. In regard to protocol, participants performed endotracheal intubation using direct laryngoscopy on an adult mannequin during simulating CPR, with trials of both mechanical and manual compressions. The order in which compressions were delivered was randomized for each participant to minimize the learning curve bias. In terms of statistical methods, paired t-tests were used to control for intraoperator correlation. The primary outcome was time to intubation, comparing mean time to intubation between the two trials. Secondary outcomes included overall success rate of intubation and perceived confidence level as expressed by a 5-point Likert scale. The population consisted of 32 emergency department physicians, 38% were female and 62% male. 78% had 1 to 5 years of experience, 16% had 6 to 10, and 6% had greater than 30 years experience. In regards to primary results, the mean time to intubation during manual compressions was longer compared to that of mechanical compressions, roughly 21 seconds compared to 15 seconds. However, this result was not statistically significant. The secondary results showed that 53% of participants had higher confidence of intubation during mechanical CPR relative to manual CPR, and 47% had no change in reported confidence level. For mechanical compressions, there was a 100% first pass success rate. For manual compressions, there was a 97% first pass success rate. By way of discussion, a prior randomized crossover mannequin study using intern-level providers showed a 75% first pass success rate using direct laryngoscopy during mechanical compressions. Our study showed a 100% first pass success rate using similar settings. As previously mentioned, we found no prior studies comparing intubation between manual and mechanical compressions. Our study showed shorter mean intubation times for mechanical compressions relative to manual, though not statistically significant. Additionally, 53% of participants expressed greater confidence in their intubation attempt during mechanical compressions. These results were contrary to our initial hypothesis, which put forth that intubation would be more difficult during mechanical compressions. One explanation as to why this was not the case looks at the physics behind mechanical compressions. Here, the chest is compressed between the piston and the backboard, which limits the overall movement of the body on the bed. In regard to future studies, video laryngoscopy could be substituted for the direct method used in this study. A prior systematic review showed improved vocal cord visualization in video-guided methods. Additionally, it would be reasonable to see if these results translated to either human or cadaver trials. Limitations of this study included small sample size and the fact that the simulation mannequin does not fully simulate the difficult airway scenarios seen in a real-life resuscitation. In conclusion, under simulated conditions, there were no significant differences in time to intubation by emergency physicians during manual and mechanical compressions. Prior to tube placement confirmation, physicians were less confident of success during manual compressions. Future studies should look at how this translates to human or cadaver subjects, as well as how the use of video-guided laryngoscopy may influence time to intubation and perceived confidence level between manual and mechanical CPR.